Good afternoon. It's my pleasure to be able to share with you a presentation that I had the honor of giving at the Nursing Research Conference at FSU's College of Nursing on April 13th. And at that time, the discussion was whether clinical agencies such as TMH and academic centers such as FSU's College of Nursing could actually be research partners. And academic health science schools and health service settings share common elements in their missions: to educate, to participate in research, and excel in healthcare delivery. There also may be very distinct differences in the business models, the incentives, and the approaches that an academic setting or a service setting may use in terms of problem solving. Leadership processes, work processes are different. There may be real differences in priorities. So actually, the key question becomes, can unnatural alignments occur? Let's explore if there could be a common commitment that would actually accelerate the appropriate use of evidence in clinical practice and create an organizational structure that would optimize opportunities for partnering, that would leverage shared resources to achieve the goal of really accelerating clinical practice. So the research and scientific priorities of each sector are very different. In the university, for example, the large federal grant funding mechanisms such as the NIH, the National Institutes for Health, and the Agency for Healthcare Research and Quality drive the research priorities in their setting. In the health services sector, like TMH, the Centers for Medicare and Medicare Services and individual consumers and private payers drive quality improvement priorities through reimbursement-based incentives, and they publicly report quality measures. In the university setting, accreditation boards such as the Commission on Collegiate Nursing Education and the National League for Nursing monitor their quality metrics. In the healthcare system, the Joint Commission serves as the accrediting body, whose oversight is essential for reimbursement. Rewards for excellence also differ between the sectors. The university strives to obtain national ranking based on educational programs and grant acquisitions, the diversity of their faculty, knowledge generation, and enrollment quotas. The health system strives to achieve recognition for quality through public reporting of outcomes and prestigious distinctions such as the Baldrige Award or magnet recognition. Deans and hospital executive officers may have very different reward structures from their boards. In 2000 and 2001, there were two game changers that occurred to launch discussion, if not actions, for academic healthcare centers to design and develop systems for speeding translation of scientific discoveries, to move from concepts to practices. The NIH Roadmap Initiative of 2000 formed a new agenda for improving public access to new scientific knowledge about health in an effort to return the investment that the public has made to science through more rapid development of technologies and behavioral interventions and communicating research results that could be applied to patient care. At about the same time, the Institutes of Medicine published the first consensus report on quality and patient-centeredness in care. It was entitled Crossing the Quality Chasm. Now, the good news was that there were monies attached to the NIH roadmap and an imperative call to action to translate the best approaches to care by the IOM publication. So, in other words, we needed to change the clinical setting into a living laboratory. Now, the challenge became implementation. How can you align the approach to problem solving of academic research studies with the operational processes and the evaluations used in the service setting? Design, analysis, timelines are all very different. Academic scientific inquiry could not be produced rapidly enough to accommodate the response times of the reimbursement-driven service setting. And I want to take a moment and make an aside. This reimbursement-driven incentive should not be seen as a mechanism to make money. The money that is involved in outcomes, pay for performance, if you will, are monies that the hospital earns that would be left on the table if certain quality measures weren't achieved. So it's not really new money. It's money that would come to you that you have actually earned. These are dollars that would then be available for technology, staffing, payroll, and benefits for patient care and outcomes in a not-for-profit hospital like TMH. So back to the implementation differences. In the service setting, nurses, distant from the budgetary dependence of university faculty or external funding, were really very impatient with the long academic project timelines and perceived external funding processes. They saw them as a laborious waste of time, yielding impractical results, available long after the presenting clinical need seen in patients. On the other hand, academicians often view the data analysis of performance improvement to be a naive approach to deep underlying issues, characterized by flawed design, failure to deal with appropriate hypotheses, failure to test rigorously, confounding and bias involved in that. So missing from this scenario was a vision for a combined approach that improved long and short-term patient outcomes, and an analytic strategy that recognized the appropriateness of each system's respective function. So what if we could dream? Close your eyes with me for a moment. What if we could create a jointly funded institute integrating existing activities from both the academic and the service sectors? And in this dream, could you envision that resources would include clinical staff and student training and mentoring? That a pilot research grant funding program could be launched? That there could be mutual support to access existing data? And developments would include an appreciation for a wider range of investigative methodologies and cross-discipline teams with skills to integrate research in daily practice and improve patient outcomes. Not a bad dream to have. Let's back up to reality for a moment. Healthcare needs of the global population are changing, focusing more on quality and safety, the aging population, a limited healthcare economy, and health policies that demand resizing the workforce in many settings. Effective responses may depend on academic service partnerships, and nurses deserve science-based, validated innovations. Partnerships provide opportunities to leverage clinical, intellectual, and financial resources to generate new knowledge and translate that knowledge into innovative, real-world patient care practices as expediently as possible. Now, one of the significant advantages that nurses have is the ability to exert a positive influence on timeliness by increasing the use of evidence at the point of care, and nurses are at that point of care. They have the ability to integrate qualitative and quantitative outcomes and to develop multidisciplinary teams of clinical staff and the university-based faculty and students. We are all together as nurses at that point of care. So alignment of seemingly disparate research and educational goals is imperative to improve patient care and is more effectively achieved through partnership. Remember the dream of just a few minutes ago? An effective alignment of academic and health service goals to direct resources and personnel toward research and clinical practices of professional nurses, students of nursing, and multidisciplinary research, which will contribute to the national priorities for safe and quality care. That's the dream. What about the reality of a true partnership? Well, let me give you 2 examples. In 2011, the Duke Transitional Nursing Institute was established, and we all recognize the prestige of Duke University. The institute was established with combined funding from the Duke School of Nursing, the Duke University Health System, and the NIH-sponsored grant that I mentioned earlier, which provided seed money for collaborative research efforts. The Duke Institute entails unit-based research teams, supported by a partnership structure that integrated key research and care procedures and targets and defined priority outcomes. That's 2011. On the opposite side of this table, you'll see that in 2009, FSU's College of Nursing and TMH, via our respective foundations, established a Nurse Scholar Program to create and sustain a culture of inquiry between TMH and FSU's College of Nursing. Our program has established the funding for a joint faculty member who, via Advanced Practice Nurses and the Research and Evidence-Based Practice Shared Governance Council, has created and implemented educational programming, a methodology for inquiry, and contributed research findings and publications which have directly impacted patient care and outcomes. Now, there are distinct differences between these 2 examples, but I know, and I can tell you that I know, because we validated the following by consultation and a site visit by an external nurse scholar in July of 2011. And that consultation has taken place, and what that scholar told us was that she could see evidence that we had endorsed common values between the College of Nursing, the academic setting, and TMH, the service setting, that there was a commitment of leadership by both components, that we were making progress on the journey to Magnet, that there was a strengthening of evidence-based practice that was actually reaching patients and families, that we were sharing resources, human resources, physical space in our Nursing Resource Center and at FSU's College of Nursing. We were sharing electronic library services, and we had joint appointments for our advanced practice nurses in the College of Nursing. That survey also said that there has been direct input into curriculum at the College of Nursing and the shared governance model at TMH. So the partnership is real. Now, a defining characteristic of a learning healthcare system is the nimble use and creation of new knowledge such that existing population data inform real-time, individual-level patient care in an ongoing, reiterative manner. Now, that quote comes from Olson in the literature, but I believe that by the work that's going on in our true partnership, that we can be defined as a learning healthcare system. So what's on the horizon? My vision would include a retreat focused on collaboration for training and mentoring of our research teams together, improving methodologic approaches for data collection, warehousing, and access and use of data, integrating multidisciplinary students and staff into our research teams, and becoming the model for real-world point-of-care research. The conference at FSU last week was proof of progress and potential in clinical agency and academic research partnership, What's happening every day between TMH and the FSU College of Nursing shows that that proof is actually coming to fruition. Thank you.